Good afternoon, and thank you all for joining us today for our web event, looking ahead to the end of the Medicaid continuous enrollment requirement. We are thrilled that so many people were able to join us for this really important discussion. Before I dive in, I want to note that today's briefing is being recorded, and the link to the recorded web event and to the presentation slides will be emailed to everyone later today. Also, we are saving time at the end for Q&A from those of you who are listening in. So please send us questions using the Q&A function at any time during the presentation. So with those logistics out of the way, let's get to the content. We know that Medicaid enrollment has grown significantly during the pandemic, in large part due to the continuous enrollment requirement that prevents states from disenrolling people in exchange for enhanced federal matching dollars. These requirements help to ensure coverage for millions of people during the public health crisis and also halted churn in the Medicaid program where individuals may cycle on and off the program. From February 2020 through September 2021, Medicaid and CHIP enrollment increased by 13.6 million or 19%. However, when the public health emergency ends, states will resume processing renewals and redeterminations, and millions of people could lose coverage if they're no longer eligible or if they face barriers completing the renewal process, even if they remain eligible for Medicaid coverage. Earlier today, we released the results from our 20th annual survey of state Medicaid and CHIP program officials that was conducted by KFF and the Georgetown University Center for Children and Families, or CCF. The full report can be found online, and it is really chock full of information. It's a huge undertaking to complete, so I just want to recognize all the authors from KFF and CCF and other KFF staff that were involved with the report and this briefing, including our production and communications teams, as well as all of the state officials who took a lot of time to complete the survey. The survey was conducted in January 2022, and it presents a snapshot of actions states were taking to prepare for the lifting of the continuous enrollment policies that have been in place, as well as Medicaid and CHIP eligibility levels and key enrollment and renewal procedures that have been in place during the public health emergency. The preparation for and implementation of the many pieces involved with the unwinding of the PHE will be a huge challenge. Earlier this month, after the survey was out of the field, the Centers for Medicare and Medicaid Services released guidance for the states that emphasizes strategies to promote continuity of coverage and to avoid inappropriate coverage terminations when the PHE ends. State policy decisions will continue to evolve, particularly in light of this guidance. However, even with this guidance, key policy choices, as well as the implementation strategies about approaches to unwinding, will vary across the states, and these choices will have major implications for Medicaid enrollment and broader coverage. So with that very brief overview and context, let's get started. First, we're going to hear from Jennifer Tolbert from KFF and Tricia Brooks from CCF, and they're going to walk us through some high-level findings from the annual survey. And then we are really looking forward to hearing from the folks who are on the ground to hear their perspectives as they prepare and look toward the unwinding of the continuous enrollment requirements. We will hear from Jamie Snyder, who's the director of the Arizona Health Care Cost Containment System, Lorelei Kellogg, who's the Deputy Director of the New Mexico Medical Assistance Division, and Jody Ray, who's the Director of Florida Covering Kids and Families. So Jen, I turn it over to you.
Thanks so much, Robin. It's a pleasure to be here, and I'm glad you all could join us for what I anticipate will be a really informative discussion. So I am going to present Tricia Brooks and I will present findings from the survey. And while we're going to focus primarily on findings around state plans for returning to normal operations, I want to start by making a few quick points about Medicaid and CHIP eligibility levels during the past year. With the maintenance of eligibility requirements in place throughout 2021, Medicaid and CHIP eligibility levels were stable. Notably, Oklahoma and Missouri implemented the Medicaid expansion in July of 2021, bringing the number of states that have adopted the Medicaid expansion to 39. In these states, eligibility levels for parents and adults without dependent children were at or above 138% of the federal poverty level. which was about $31,800 for a family of 3 in 2022. Eligibility levels for children and pregnant women held constant from 2021 at 205% of the poverty level and 255% of the poverty level, respectively. Next slide, please. However, in the 12 states that have not implemented the Medicaid expansion, eligibility levels for parents are very low, and only Wisconsin covers adults without dependent children. The median eligibility level for parents in these states is 39% of the poverty level for less than $9,000 for a family of 3. In 9 of these states, eligibility is based on a fixed dollar threshold that does not account for inflation. So with inflation rising in the past year, eligibility levels in these states have actually fallen. Next slide, please. So now I'm going to turn to the findings on how states are planning for the unwinding of the continuous enrollment requirement. CMS requires states to develop a comprehensive plan for restoring routine operations, including how they will prioritize outstanding eligibility and renewal actions. As of January 2022, just over half of states had settled on their approach. Among the states with plans, 11 will target individuals who appear to no longer be eligible first, and this is referred to as a population-based approach, while 9 states will conduct fresh renewals based on an individual's original renewal month or by targeting older cases first, and that's a time-based approach. 7 states have indicated that they are planning to adopt a hybrid or combination approach. And examples of this include targeting individuals who appear to be ineligible, but focusing on older cases first, and also deprioritizing pregnant individuals, but otherwise processing renewals by the individual's renewal month. Now, importantly, at the time of the survey in January, 16 states had not yet made a decision on their approach. Next slide, please. So the vast majority of states plan to take up to a full year to process the backlog of renewals. In recent guidance, CMS permits states to take 12 months to initiate and 14 months to complete all renewals. CMS also encourages states to initiate no more than 1/9 of their total renewal caseload each month to reduce the risk of erroneous coverage terminations. Some states are facing fiscal or political pressure to move more quickly, however, particularly because the enhanced federal Medicaid funding will end before most states return to normal operations. And already we learned from several states in the report or in the survey that they have indicated they will plan to process all renewals in less than 12 months. One thing I will note here, as Robin said at the outset, the survey was conducted in January and states' plans may have changed since then. We did in fact hear from a state earlier today that had initially indicated they were taking 3 to 6 months, and that has changed. So now I can report that there are actually 40 states that are planning to take up to the full year. 4 states have said that they will take 6 to 9 months, and 4 states will take 3 to 6 months. The risk of moving more quickly than a full year is that there will be less time to conduct outreach to enrollees, and the sheer volume of renewals could overwhelm the capacity of both staff and systems to process them. Next slide, please. The 2-year COVID emergency has likely exacerbated long-standing difficulties in reaching enrollees by mail, which is the primary method states use to send renewals and requests for information. Most states are taking proactive steps to update mailing addresses before the end of the public health emergency, including conducting direct outreach to enrollees and checking for updated addresses in SNAP or other benefit programs. States are also working with Medicaid managed care organizations to conduct outreach and to share updated contact information. In addition, we heard from states that 35 will follow up on returned mail by phone, email, and or text to attempt to locate an enrollee before terminating coverage. Next slide, please. Many states are facing staffing challenges, including staffing shortages, as well as inexperienced staff. New staff hired during the pandemic haven't worked under normal operations and may not have had experience completing a full redetermination. So there are concerns about the existing capacity of the workforce to handle the volume of renewals that will need to be processed when the public health emergency ends. To prepare for the anticipated increase in workload, 30 states are boosting eligibility staff capacity, including by approving overtime or hiring new workers or contractors. And many of these states are taking multiple actions. And then just one other point I would like to make, which is that having timely and reliable data will be needed to monitor state progress on the unwinding. Nearly all states indicated that they could report call center statistics, so call center wait times and call center volume, but only 41 are able to report the share of disenrollments that were determined ineligible versus those that occurred due to procedural reasons. For example, not getting information from the enrollee regarding renewal or other information. CMS has indicated it will require states to report monthly data during the unwinding period, though it has not yet identified the specific data elements that it will ask states to report. And with that, I'm going to turn it over to Tricia to continue presenting additional findings.
Thank you, Jen. Next slide, please. Well, hello, everyone. Thank you for joining us. Conducting full renewals for all enrollees after the end of the PHE is a critical aspect of unwinding the continuous coverage protection. In many, if not most cases, only income needs to be reviewed at renewal. States must first attempt to verify ongoing eligibility using available data sources, such as state wage databases, before asking an enrollee to complete a renewal form or provide documentation. This process is technically referred to as ex parte since it relies on third-party data to confirm eligibility. These data-driven renewals reduce the administrative burden on both states and enrollees. Some states suspended renewals as they made COVID-related adjustments to operations. As of January, 42 states indicated they were actively processing ex parte renewals, and 30 of those states are sending renewal forms or requests for information when they are unable to determine ongoing eligibility. States are more successful in completing renewals during the PHE will have a smaller backlog of delayed work when the PHE ends. However, ex parte completion rates vary significantly across states as shown on this map. Of the 42 states processing renewals, 11 states complete more than half, while 22 states complete less than half of their renewals via ex parte. 9 states were unable to report these data. Next slide, please. States must give individuals 30 days to respond to a renewal request, but there is no federal requirement to do more than send the renewal form, followed by a termination notice if no response is received. However, sending reminder notices can increase the response rate, particularly if different communication methods are used. 41 states reported they plan to send reminders using different modes, including sending emails and text messages and making individual and automated phone calls as shown on this slide. Next slide, please. Since 2020, 6 states transitioned to state-based marketplace status, bringing the total number of SBMs to 21. 18 SBM states operate their own marketplace eligibility systems, while 3 SBM states use healthcare.gov for eligibility and enrollment. The remaining 30 states rely on the federally facilitated marketplace for all or most marketplace functions. SBM states may integrate Medicaid and CHIP into their marketplace eligibility system, which can ease transitions between public coverage sources. In 10 SBM states, the marketplace system also determines eligibility for Magi-based Medicaid and CHIP. The remaining 11 SBM states and 30 FFM states have separate Medicaid eligibility systems. Next slide, please. To implement the ACA, Most states built new eligibility systems that delinked MAGI-based Medicaid from other programs, but many have since reintegrated eligibility for other types of assistance, which may help states consolidate or align eligibility tasks. As of January, the MAGI-based Medicaid system determines eligibility for non-MAGI Medicaid in 36 states, SNAP and TANF in 28 states, and child care subsidies in 15. These counts include Kentucky and Rhode Island, the only SBM states that have fully integrated all health coverage options and non-health programs in their marketplace system. Next slide, please. 48 states now offer online accounts for Medicaid enrollees to submit and access information, up from 43 states 2 years ago. Almost all states with online accounts allow individuals to check application status, report changes, and view notices, while slightly fewer permit individuals to renew coverage through their account. Several states have also expanded the features offered, including the ability to upload documentation and the option to receive electronic notices. Next slide, please. As individuals increasingly use smartphones and tablets rather than computers, more states are taking steps to ensure that applications and online accounts can be used on multiple technology platforms. 32 states report their online applications are mobile friendly compared to 22 years ago. Similarly, 35 of the 48 states with online accounts report mobile friendly formatting. That's an increase of 12 states since 2020. Next slide, please. In closing, I just want to reemphasize a few points that Robin also mentioned. Providing advance notice before ending the PHE will enable states to refine and finalize their operational plans. States are preparing now, but they will need lead time to initiate the first steps. The Biden administration has promised to provide at least 60 days notice, but signaling even earlier when the PHE will end, if possible, would enable states and other stakeholders to ensure plans and processes are in place and ready to launch. In the several rounds of guidance and tools CMS has provided states to prepare for the unwinding, the administration has consistently emphasized strategies to promote continuity of coverage and avoid inappropriate terminations among eligible enrollees. The latest guidance offers states additional flexibilities, including working with managed care plans to help update addresses and assist with renewals or transitions to marketplace coverage, prompting some states to reassess their plans. The PHE has clearly demonstrated how continuous enrollment can eliminate churn in Medicaid and prevent coverage losses during an economic downturn. CMS encourages states to adopt strategies such as continuous eligibility, extending postpartum coverage to 12 months, using SNAP to renew coverage in Medicaid, increasing the effectiveness of data-driven renewals, and other policies to promote continuity of coverage. How states approach the unwinding will affect the extent to which eligible individuals retain Medicaid and those who are no longer eligible transition to other coverage sources. Outcomes will differ across states as they make different choices and face challenges balancing workforce capacity, fiscal pressures, and the volume of work. Careful monitoring of state progress through the unwinding period and public reporting of state unwinding plans and data collected by CMS to monitor the unwinding will be important for entities other than CMS to assess state actions. The fate of the Build Back Better Act will also have implications for overall coverage. BBB included several provisions related to the unwinding, some of which CMS has incorporated as recommendations in the most recent guidance. However, millions of people could lose coverage if those who continue to be eligible for Medicaid are disenrolled for procedural reasons, and if the provisions in the BBB that close the coverage gap and make marketplace coverage more affordable are not enacted. And with that, I'll turn it back to Robin, but I just first want to make sure to thank all of the state officials for their help and patience in collecting and reporting these data. We really do appreciate it.
Great, thanks so much, Jen and Tricia, for that great overview. And now, as promised, we're going to turn to a discussion with our panelists and hear how things are going on the ground. We are getting a bunch of questions in the chat, so I would encourage folks to keep submitting those questions. We have gotten a few questions about specific states, so I'll just note that in the report, there are many, many tables, so a lot of the state-specific information can be found in the report. But to kick things off, we heard this national perspective that had a lot of counts of states. So it's really hard to get a sense of what's happening on the ground. So it would be great to hear from each of you about some of your specific actions that you're taking to prepare for the unwinding of the PHE. So maybe we could start with Jamie to hear what's happening in Arizona, and then we'll hear from the other panelists as well.
Certainly. Thanks so much, Robin. And thank you for inviting me to be a part of today's discussion. This effort in terms of the reinitiation of our renewal activities is really top of mind for the agency here in Arizona. Our enrollment has grown by over 490,000 over the course of the last 24 months. And that's about a 26% enrollment growth rate. Like many states, most states, in fact, we've continued our eligibility processes behind the scenes over the course of the public health emergency. Of course, we haven't disenrolled anyone, consistent with the continuous enrollment provision under the Families First Coronavirus Response Act. I should note that in Arizona, we're fortunate that between 75 and 80% of our enrollments are completed using ex parte processes. So in an automated fashion, we're able to ping the federal hub and other data sources to complete those enrollment processes. Because we've continued over the course of the public health emergency to process renewals behind the scenes, we do have a sense of the number of individuals who either may be ineligible or individuals who have failed to supply documentation in order to complete the renewal process. And we believe that number stands at right around 500,000. So we've already initiated a series of activities to proactively outreach to members in anticipation of the end of the PHE, which now looks like it could be the middle of July, which would allow us to initiate our standard enrollment processes starting August 1st. So we've engaged in a social media campaign, outreaching to members and providers, encouraging members to update their contact information. We've provided a messaging toolkit to our contracted health plans. As you know, Arizona is a managed care state, so we work very closely with managed care organizations in these sorts of efforts. And we're partnering with our MCOs very specifically in providing them with a series of files that will help them in outreaching to members who may be in jeopardy. Specifically, we're providing them with files on a monthly basis of individuals whose eligibility renewals are upcoming. And we've provided them with a comprehensive file of those individuals over the course of the PHE that have failed to supply documentation, the necessary documentation, in order for us to finalize that redetermination. So at this juncture, the health plans are proactively reaching out to both parties, both those that are due for renewal and those that have failed to supply documentation, requesting that they engage with the system, that they update their contact information, and they upload the necessary documentation. Our commitment over the course of this process is really to minimize the loss of eligibility due to procedural issues like inaccurate contact information and failure to supply documentation. And in the event that an individual is deemed ineligible for Medicaid coverage, connecting them to alternate sources of coverage. And we're working with our health plans currently to establish the protocols around that process as well. So that gives you a little bit of a sense of how we're handling it in Arizona, but I'm very curious to hear from my colleagues in other states as well.
Great, why don't we hear from New Mexico, and then we'll turn to Jody after that.
Thank you, Robin, and thank you, Jamie, for that wonderful introduction. We have actually been doing a lot of the same things that Arizona has been doing. Like Arizona, we've continued to process renewals throughout this entire public health emergency period. So we have been able to receive updated information from folks. And as a result, where we really started with our unwinding work in the middle of last year was with data. So we really worked very closely with our eligibility vendor to create a report of our maintenance of effort population so that we could identify the status of that membership, primarily looking at individuals that may have reported information that indicates that they're potentially ineligible for Medicaid so that we could proceed with our population targeted approach. We have been strategizing on the planning for this unwinding for some time, as I'm sure everybody else has. We've been prepared to do it at a couple of different points over the course of the last 18 months. So, but we're always grateful for more time, to be honest with you. And we have been also working very closely with our MCOs. New Mexico is another managed care state. About 80% of our population is enrolled in our managed care organizations. So we have been meeting with them regularly to develop communication plans. We created sort of a single communication package, I guess, for lack of a better term, that is also being shared across our sister agency. We have an integrated eligibility system here in New Mexico. So any notification or any correspondence that goes to our Medicaid enrollees frequently hits our SNAP population as well. So we've been working with that sister agency to begin some of our outreach for getting updated addresses through the standard SNAP processing. That has been really beneficial for us. So we actually targeted some text campaigns at the beginning of the year. We've seen a huge success rate with those in terms of responsiveness from our membership. And that is a platform that we'll continue to utilize throughout the unwinding period. We are also working on a sort of communication cadence every month so that we are sending reminder texts, that we're working with our MCOs so that they can reach out to their members that may not have returned their applications. Because again, like Jamie, we're really focused on mitigating the procedural denial rate as much as possible. We were working very hard on eliminating the coverage gap here in New Mexico. We have a high percentage of our population on Medicaid. It's almost 50% at this point. So it's really important to us that we avoid the procedural denials as much as possible because the potential coverage gap there is pretty significant for us. Let's see, other things that we've been doing. We've obviously been working very closely with our systems folks and our eligibility vendor to make sure that we're system ready for this unwinding. It's a pretty significant lift for our systems team. And we've been trying to communicate with them as much as possible. And they've been incredibly flexible with us, to be honest, because we keep kind of moving the target for them. So we're looking forward to getting that communication around a confirmed date. And we're hoping we can give those marching orders to our partners so that they also can start actually implementing some of these ideas that we've sort of set up to be knocked down.
Great, thank you so much. And Jody, we'll turn to you, and I wonder if you could start by explaining a little bit, because you have a different role, obviously. Your role as a navigator, and that's different from being directly in the state, and how you're working with enrollees and your role and strategies in trying to and prepare for the unwinding. So I'll turn to you.
Thank you. Well, first of all, it's really impressive to hear what New Mexico and Arizona are doing and what steps they've taken so far. I am a navigator, and I lead a team of assisters across the state. We have the largest navigator project in the country. So I think one of the things that we bring to the table is really an ability to, in part, to help facilitate some of what's going to happen on the ground. At this point, we don't really know anything in Florida, unfortunately. So I can speak to what the concerns could be, and also some opportunities that I think a state like Florida could avail itself of. I think some of the concerns that we have at the moment is the fact that we don't know what we're doing, what we're going to do. I don't think that information has gotten out there in the way that I think would be more helpful. The more informed we are on the ground, the more I think we can help the individuals who are going to have to go through these processes again. And you know, some of them have no idea why they were still in Medicaid. You know, we hear from them all the time, and we have to explain, you know, what has happened under the public health emergency and why that resulted in them being where they are. Some of the challenges that we are facing include the fact that we know we're going to need good messaging, and stakeholders should be at the table, but those stakeholders probably should include the assister workforce, because the assister workforce are going to be the ones that are going to have more contact with the consumers than anyone. I think one of the concerns is there going to be adequate staffing? Is the state going to ramp up staffing to address how many people they're going to have to do redeterminations for, and be responsive to people who are having issues with the process, don't understand the communication. And the fact that we don't have a CHIP application is a bigger challenge for us in Florida, because we're anticipating that while people should be able to smoothly transition over to CHIP or the marketplace electronically, we know that often doesn't happen, and they fall through the gaps in these processes. And having a strong assister network can really help folks navigate that process without losing them along the way. I think looking at making sure that the messaging is simple, and I've seen some of the recommendations that came out of Georgetown, for instance, and CMS, that the messaging shouldn't use, you know, vague things like you may or may not have to do things. And we don't know who is going to be up for redetermination when this starts. We don't know how many are going to be processed. We don't know what the plan is. And I just think the lack of information is probably part of the challenge, and our inability to be appropriately prepared to help people. Because I think our biggest job is to be able to help people have some expectations. If we can set expectations on the ground for consumers, I think they will feel less anxiety about how they have to go through the process and what the communication means to them. I think the other thing is, you know, and this has already come up, is certainly ensuring that the state has the best database of addresses for its enrollees as possible, so that people will get the communication. But where they're going to be steered, I think, is relevant. In a state like Florida, an FFM state, also an assessment state, not a determination state, I think it's really helpful if people are referred to someone who could provide assistance. We do know that processing time right now isn't exactly timely always, because of the amount of people that have been getting into Medicaid. And I do think, again, I think having folks on the ground, having a workforce on the ground that understand the processes, understand the policies can be a big help. So I think engaging a team of folks on the ground that are doing enrollment work, we're going to have to figure out how to get people in, the kids that are going to be redetermined not eligible for Medicaid anymore, and potentially could go into CHIP. A very big concern that we're going to lose them in that hole. And I think that we can really assist with that. Clearly, having a CHIP application would be helpful, so that we're able to more directly get them into these programs that they're eligible for. So I think teaming up with navigators and other types of assisters in the state is a real advantage for the Medicaid eligibility programs. I mean, you have a workforce, and use them. They want to step up. They want to be engaged. They understand the systems. They understand what's going on. And I really think we can help keep people from falling through the gaps along the way and losing them. So I think these are some of the things these are the questions we have. These are the questions we don't necessarily have answers to, but I think clearly outlining what the plan is and being transparent about it will go a long way to ensuring that we lose less people in this process.
Great. Thank you so much, all of you, for that overview. I want to key off what you were just saying and pick up a little bit on some of the things others have mentioned. It does sound like whether it's navigators and assisters or MCOs, are there other key partners that folks are working with that you'd like to highlight that are key stakeholders in the decision making and implementation of policies that will be adopted? And if there's any strategies that folks are using to target harder to reach populations, so people with limited English proficiency, people with disabilities, folks that having disruptions in care would be really problematic. So both the partnership and targeting hard to reach populations. I'm wondering if anyone has anything to add on to that.
Well, I think you make a good point, because I think that's one of the invaluable things about the assister workforce is that that's what we already do. We're trained to do that. We have an infrastructure in place to deal with cultural barriers or issues, all kinds of hard to reach populations, language and literacy challenges. We're also on the ground, so we're addressing, transportation issues. So we're out there reaching people that maybe shooting out emails isn't going to be sufficient enough. So I think, taking advantage of the fact that we've got people out there that are speaking the languages and know the populations on the ground, and that is their job, I think is a win-win, because you don't have to train this workforce for that.
Robin, I'm happy to tag on to that. Jody, absolutely agree with you. I think assisters are a natural and important partner in this process. And we've actually encouraged our contracted health plans to become assister organizations, and most of them have. And in the event that they haven't, they're partnering with a known and trusted assister organization. So absolutely agree with you on that point. I also think that provider associations are really important. Most notably in Arizona, we're partnering with the Alliance of Federally Qualified Health Centers. They serve a large portion of our population. They're on the ground meeting with members day in and day out through their clinical care. Absolutely see them as a resource, even in terms of getting members to engage with the eligibility system, update their contact information, make sure that they have all of their appropriate documentation uploaded. Robin, to your second question about specific populations, one population that we're focusing a fair bit of energy on is individuals experiencing homelessness. So we actually conducted a survey recently of our sister organizations to really assess their readiness in supporting individuals experiencing homelessness who may be, may need to engage with the eligibility system, again, update their contact information or supply additional documentation. In addition, I mentioned the files that we're supplying to our contracted health plans so that they can do proactive outreach. In the event that an individual self-reported homelessness, that flag is contained in the eligibility files that we're supplying to health plans. And we're asking that the health plans really focus and start with those higher risk populations in their proactive outreach. So clearly, individuals who are homeless or at risk of homelessness are among those at-risk populations.
Yes, again, both Jody and Jamie have covered some of the same things that New Mexico is doing. We are working with our MCOs to do some targeted outreach to individuals that they've identified as high-risk members. So part of the data that we've been receiving from our eligibility vendor is, as I said, it's financial information. It's indications that these folks might not be eligible for Medicaid any longer. So we're trying to isolate the individuals who we consider high risk, those individuals who are disabled, who are receiving home health care services, to really make sure that we have a much more warm transfer for those individuals if they do end up being disenrolled from Medicaid, so that we can make sure that we are getting them onto the exchange. We are also working with our community organizations. We've just initiated some of this outreach with them, specifically to work with individuals with limited English proficiency, as well as other folks that might be considered disabled community members who may not be identified through that standard of care report that we've pulled. So we're trying to make sure that we don't have too many gaps in that. And again, we're also really working with the exchange and those individuals who are signed up through the exchange to be brokers, to try to develop a process for them as well so that they can assist with that outreach.
Great. So there's a lot of moving pieces, clearly, that are going on, a lot of uncertainty, as we don't even know exactly when the public health emergency will end. So I anticipate many challenges. Jody outlines many challenges. We've already discussed a lot about updating contact information. I'm wondering if there's any other key challenges that you might want to highlight. I know all of this will be a big challenge, but if there are other key challenges that you're thinking about as we move toward the possible end of the PHE.
I think one of the other sort of large concerns for New Mexico is the administrative burden of this unwinding process. Even though we have been processing recertifications and taking changes of circumstances throughout this entire 2-year period, the return of the requirement to complete these recertifications for our E and E staff is pretty significant. As I'm sure other states can relate, and I see Jamie nodding her head, the staffing issues sort of nationwide have impacted our eligibility staff. So we're not full. And we have been working with our data analytics team to try to establish projections as to what the staffing need is going to be. And it's concerning, and it's a lot of work for people to kick back in, particularly because I think once the messaging really starts to sink into our members, there's the potential that folks are going to panic. They're going to be calling our call centers. They're going to be sending things in multiple times. They don't want to lose their Medicaid. And so having clear communication so that we can mitigate that administrative burden has been really important for us.
Yes, absolutely agree on that point. We are very concerned given current workforce challenges and the level of turnover among our eligibility team members. One of the things that we are looking at as an opportunity, and I really appreciated CMS's nod to this opportunity in their recent guidance, is the availability of waivers under Section 1902 E14A, which can create some efficiency in eligibility processes. For instance, being able to use that SNAP income verification as a proxy for income at the on the Medicaid side of things, or being able to use that self-attestation of zero income to verify income levels among our membership. I think those waiver opportunities are certainly something that we're looking at, given some of the challenges we're facing and the need to really think about every option for creating some additional efficiency in the renewal and redetermination process.
Great. I think at this point, maybe we should turn to some, we're already answering some of the questions that I'm seeing in the chat have been coming up, but I wonder if we should turn to some of those so I can invite Trisha and Jen back on. I think this is a broader question that's come up a few different times, and I think Jamie had answered this in anticipating that maybe the public health emergency would be extended another time. You were thinking about that July date. I'm wondering if Jody or Lorelai have a working estimate or anticipate or are anticipating when the public health emergency is going to end. There's some anticipation that it might go through the end of the calendar year. It's hard to know, but I'm wondering if you're working under a particular assumption.
We are.
Sorry.
No, sorry. We are working under the same assumption as Jamie. And we are actually working with our systems team to try to get at least some of the changes that we're anticipating implemented by May. Mostly, to be honest with you, so that we can have them ready to go and we don't need to worry about them anymore. But I think the date that we're targeting right now is that mid-July date, with the assumption that we will see one additional 90-day extension of the public health emergency.
I'd like to say I have any more solid information on that, but I really don't. I mean, that's all we have to work off of. I think it would help to know so that, you know, we can certainly prepare people on the ground, because we already do a lot of Medicaid enrollment or assist a lot of Medicaid enrollees. You know, realizing the numbers that could be impacted by the unwinding, I think it'd be really incredibly helpful to be able to actually be prepared for what, when that's going to start. I think gearing up for that would be essential.
And Robin, if you don't mind, just wanted to add on to that. I know today's conversation is really focused on eligibility, but I think it's important to note that there's a whole range of other flexibilities that states have pursued over the course of the public health emergency, which will terminate as well. And just wanted to note that because there's not a ton of discussion on those, but like there are provider enrollment flexibilities, prior authorization flexibilities, telehealth flexibilities. And I want us to be cognizant of the impact that the termination of those flexibilities will have on members and providers and stakeholders as well.
That's a great point. And I think we did hear from Arizona on some anticipated numbers in terms of estimated people that may no longer qualify when the public health emergency ends. I think we have a question to New Mexico if you have an estimate of a similar estimate.
So we're estimating about 85,000 individuals would be what we're anticipating actually rolling off during the unwinding process. The rest of our MOE population we've identified as being potentially eligible. So, you know, I'm not the math person, so I have no idea what was done with the numbers behind the scene, but I know that we took into consideration sort of standard procedural denial rates when we were developing that number. So it's a little less than 10% of the current enrollment in New Mexico.
Great, thanks. And I think, we have in the report that 11 states are using text as a method of communication with enrollees. And we have a question about, you know, why are more states potentially not using text information? And if you have used text, is that an effective method of communicating with enrollees? And curious from navigators and assisters as well, if text is a common method for.
Actually, but particularly when we're doing the marketplace applications, I would say the majority of the folks that I've seen prefer some kind of electronic communication versus the paper. And in terms of email versus text, I typically see text more often than email, but I don't know that that is reflective of the whole state. I'm just giving you sort of an anecdote from personal experience, but predominantly people seem to want electronic communication versus paper email or paper mail and snail mail, because they oftentimes don't look at that, which is one of the risks we've always had, especially coming from Medicaid agencies. That stuff can get lost in the shuffle. And so I think incorporating text as a direct communication, especially for this particular unwinding, I think could go a long way in potentially at least getting what is happening in front of those individuals that are going to be impacted.
We've been using text campaigns pretty consistently in New Mexico, and we're still, again, I'm not the math person, but we're still doing some analysis on those success rates. But I can say sort of just anecdotally that we see a pretty significant spike in activity after those text campaigns go out. So, you know, huge influx of applications, huge influx of phone calls. So people really are responding to those texts. And one of the things that we are trying to do in an effort really to address kind of the administrative burden of our call centers and our field staff is that New Mexico does have RPA capabilities, which are AI bots that we can utilize to make small updates on individuals' case records. So we're trying to leverage that in order to facilitate some address information capturing for folks that we don't think we have good addresses for. So that automated kind of non-human resource intensive way of reaching out and receiving information is something that we're really focusing on here.
Our experience in Arizona has been very similar in terms of the success of texting. We use it, our health plans use it. I think it's the way in which members prefer to interface with our system. I think we have additional work to do in terms of making our system more user-friendly in terms of using a mobile device to interface with the system on a routine basis. And we just actually added a bot to our eligibility page. So more to come in terms of the success of that effort, but I'm encouraged by your experience.
Great. I have a little bit of a technical question, but we know that individuals who continue to be eligible may cycle off if they face some barrier in re-enrolling. There's a question about the role that retroactive coverage can play. So if someone loses their coverage, you know, will and can retroactive Medicaid coverage provide some sort of backstop in providing more continuous coverage for people that may fall through the cracks?
Yeah, there's the potential for retroactive coverage, and then there's also the 90-day redetermination, depending on what results in the closure for that individual. So again, New Mexico is very focused on mitigating those coverage gaps. So we are able to provide retroactive coverage in the cases that it's appropriate, and then the 90-day reconsideration in the places that that's appropriate. So that is not changed from our pre-pandemic processing.
And I think one of the other exciting developments in the recent guidance offered by CMS was some language that specified that we're able to, I think, extend that period where we can re-enroll an individual if they fall off into their plan of prior enrollment up to 120 days. If I'm not mistaken, please correct me if I'm wrong, but we were excited to see that in the guidance that they offered on the 3rd of this month.
And then I guess we have another question particularly related to Florida. Florida was one of the 3 states that was undetermined about whether they would forgo federal matching dollars and start disenrollments potentially earlier. I'm just wondering if you have heard anything more from the state in terms of plans. Again, we were in the field prior to the new guidance, so things are continuing to evolve, but I'm wondering if you have heard anything on the ground about that.
No, and I think that's the biggest challenge that we're having is that, you know, most of the folks that I'm talking to that are going to be involved in this in some capacity, whether we're responsible for helping people navigate those processes, or the outreach and education piece. The communication piece is huge when you're engaging the assister workforce. The health education piece, the health literacy piece is significant. And unfortunately, we still don't know a whole lot, which isn't really helpful to answering your question. But I think one of the things that, and this, you know, Tricia, this is going to bring back old times. I think we always forget, you know, one of the things that is so important is we want to also reduce the churning. So the people coming out that should be in, and then, you know, being administratively processed again, back in. And that's expensive to the state. That's costly. And again, I think we can play a role in reducing the churning, particularly for those that are in Medicaid and should be remaining in Medicaid, but may lose coverage for failure to respond to a notice, not understanding what they're supposed to respond to, or confusion, you know, particularly since we don't know who's being redetermined now or when, And is that going to be, are we going to be doing, you know, a set amount each month? Is there a percentage? Are people going to have, you know, are we going to have staggered renewal dates? How do we communicate that in a way that doesn't confuse one person versus the next person who they're speaking to and finding out, no, you don't have to re-enroll for another 3 months? Could result in people losing coverage just because of misinformation that, you know, permeates, and they're resulting in a significant amount of churning when it comes to enrollment as well.
Great, and I know Jody's already spoken to this, but I'm wondering if, as a last wrap up, if Jamie or Lorelei want to just talk about any other key methods or strategies that you might be thinking about to facilitate transitions to other coverage, whether it be CHIP or marketplace coverage, if people are no longer eligible for Medicaid.
We have been working both with our state-based exchange, which is in its infancy. It was implemented for this most recent open enrollment. So it's a very new exchange, but we've been working with our partners there, as well as our MCOs, with kind of a focus on the procedurally denied group. So conversations about data sharing, making sure that we're able to get information about that population. There was also some information in the guidance that came out most recently with CMS that extended some flexibilities for our MCOs in terms of what they were allowed to do with those members. So we're really looking very closely at that. Again, the expectation is that we'll see a higher percentage of procedural denials than normal, particularly in the first part of the unwinding, as people get back into the habit of having to submit their documentation to the agency. So I think that that's really our focus. We have a couple of different conversations going on right now about the best strategy for that. I'm certainly open to ideas. I don't know if Jamie has any suggestions that Arizona's working on that she could share, but that's kind of our targeted focus right now.
And I would just kind of going back to Lorelei's point about the opportunity for health plans in terms of connecting members to other products that they may have, corresponding products. I think CMS has opened the door pretty widely on that, and they're really allowing plans to educate members about the availability of other products that they might offer and that may be offered by other plans as well. So I think that's really exciting. I will say, in my role as the president of the National Association of Medicaid Directors, one of the things we're doing that we're hoping will be helpful is really gathering an inventory of best practices from around the country, from Medicaid programs. And we're going to house that information on our online portals so that Medicaid agencies can access that easily and readily throughout the process. I think we have a lot to learn as we move through this process. And I think that sort of inventory can be really valuable to us as we try to dial things in to ensure that individuals maintain coverage or are connected to alternate coverage that may be available to them.
That sounds great. Thank you for mentioning that. So I think we are about to conclude. I think if we all walk away from this briefing knowing that the unwinding will be a huge undertaking and that the policies and implementation of those policies will vary considerably across states, but collectively these decisions and how they're implemented will have major effects on coverage. So that, I think, was definitely the key take home. But I want to wrap up the webinar with a really huge thank you to everyone who attended the webinar, and also a huge thank you to our panelists for sharing their time and expertise. I want to remind everyone that the slides and recording will be available later today. And with that, that concludes our webinar. Thank you so much.
Thanks so much.